Sure.
So I have been given the topic of oligometastatic disease, definition and practice patterns. So if we go back to way back in 1804, and more, I'm taking breast cancer as an example. So the health stories theory said that it is a localized disease. For that matter, once upon a time, we all thought that cancer was a localized disease, and it took more than a century, more than 150 years, that Fisher et al. In 1980 came up that breast cancer is a systemic disease even at its inception, and hence the role of systemic therapies. So, in practically speaking, in today's date, even when we can easily say that when we are talking of malignancy or when we are talking of cancer, is it really localized when we talk about it upfront? So we know there is a spectrum. There is a spectrum of pattern. What appears to the eye as localized, we still know that cures are possible, but which appears as a disease which is spread to multiple sites, then basically we go for systemic therapy, and local treatment may be required for something like toilet mastectomy or for symptom control. But there is definitely a term, a state in between, which is where we can say the meds are there, but still they still appear to be quite localized, and in a subset of these patients, cure may be possible. So again, it is oligometastatic disease is basically a specific condition between a disease which is curable and a disease which is definitely incurable. So somewhere in between, we have a few subset of cases, few cases which maybe possibly can be treated with a curative option, and not a stochastic oddity as said by Hellman. It is based on a state of limited metastatic capacity, and rather it is not only with one particular tumor or one particular disease, rather a characteristic of many tumors during their clinical evolution. So if you look at the biology of the disease, if you look at the molecular pattern, the micro RNA expression, is it different between the oligometastatic disease or a polymetastatic disease? Then the answer is no. The biological features may tell us that the patients who present with oligometastatic disease may have a favorable biology or may have less heterogeneity. But patients who present with polymetastatic disease, again, the heterogeneity is more. But can I divide? Because it will take me a very, very long time to actually ascertain whether which this particular patient, this metastatic disease is going to be have a favorable biology or a poor biology. So at present, what is that tells us, that helps us in diagnosing the oligometastatic disease? Needless to say that biological rationale may be there, but will definitely not help me. No molecular markers are there that can be defined for used for oligometastatic disease. It is presently basically only imaging defined. So as the imaging advances, the new technology in imaging, probably more and more of these oligometastatic disease, which we actually thought of locally advanced disease, probably will be identified, and hence there will be much more recommendation of incorporating the higher advanced imaging technologies in even in the early cancer. So, for example, we know that in the oligomer inclusion, the imaging techniques which have been advocated is something like PET CT for each and every patient, and a MRI also of the brain, so that you can actually identify the subset of these oligometastatic disease. So there has been lot many debates, lot many discussions, and we have one of those latest consensus recommendation from both for ESRO and EORTC. So it is not putting a label of oligometastatic disease. It is not one disease. It is not always the same. So there may be lot many factors. Is it actually a oligometastatic disease, which is de novo present as oligometastatic disease, a genuine oligometastatic disease? And if it is a genuine oligometastatic disease, is it de novo oligometastatic disease, or a disease which had earlier presented as an early disease or a locally advanced disease, and now in a recurrent setting, it is a oligometastatic disease. If it is a de novo oligometastatic disease, whether it is a synchronous or it is a metachronous oligometastatic disease. Similarly, there may be a spectrum of patients which have been induced as oligometastatic disease, were polymetastatic to begin with, and over a period of time, after systemic therapy, there was only residual oligomets, or possibly the mets disappeared and then it again started increasing, induced oligometastatic, or while on systemic therapy, the lesions initially decreased and then progressed further. So it is not as simple as saying that it is oligometastatic disease. So you have, this is just a diagrammatic representation of that complicated chart which I just showed. It can be either de novo oligometastatic disease, a disease presenting with oligometastatic disease, which can be synchronous within 6 months, or it can be metachronous one after another beyond 6 months, or it can be metachronous oligoprogression also while the patient is under treatment for the metastatic disease. Similarly, it can be a repeat oligometastatic disease, a repeat oligometastatic disease, possibly a localized disease to begin with, and then the patient presents as a oligometastatic disease after a treatment-free interval, or a repeat oligoprogression appearing after a treatment-free interval and then while on systemic therapy again progresses, but it is a oligoprogression, or a repeat oligopersistence, repeats after a time but remains as oligometastatic, and while on systemic therapy it persists as oligometastatic. And again, there is a whole spectrum of induced oligometastatic disease, which can be induced oligorecurrence or induced oligoprogression, initially induced from polymetastatic to oligometastatic and later progressing or persisting. So there are final differences between these definitions, and possibly can they all be clubbed together and dealt the same way? And then it is again a topic of debate. We know that the age-old dictum remains. So do all of them behave the same way, whether it is de novo or it is a repeat or it is an induced oligometastatic disease? We know that the disease which is less to present, so that is the reason that repeat oligometastatic disease, which were earlier probably early or locally advanced and later after a treatment-free interval now presented as oligometastatic disease, or a de novo oligometastatic disease, are the ones which will have the best outcomes and the best survivals. A patient who had a polymetastatic disease and later turned into oligometastatic disease, and the outcomes will definitely remain poor compared to the other oligometastatic diseases. So the definition seems to be evolving over a period of time. Both ESMO and ESTRO have used variable definitions, but the basics remain the same. It is a low volume metastatic disease. There is a limited number of the mets and the limited size of the mets. 5 centimeter being the common magic figure being used by most of these trials. And again, less than 5 lesions and a controlled primary lesion seems to be the most desirable thing. But the basic crux is where all the metastatic sites can be safely treated, can be easily treated, and with a curative intent. So the definition combines an artificial description with the possibility and choice of implementing a therapeutic strategy with a curative intent. So all the different scenarios which I have already highlighted may present as an oligometastatic disease, and it actually is a spectrum. It is a spectrum of disease, and of course, being oligometastatic, but whether it is an oligorecurrent or oligopersistent or oligoprogression, the outcomes may be very, very different for each and every patient. So if we go for the incidence, and if we are talking of primary breast, so oligometastatic, the incidence seems to be quite variable. In metastatic breast cancers, 50% of these cancers seem to be presenting as oligometastatic disease or the de novo. But whenever it is a oligorecurrence, if we talk about, then 17% of the cases in early breast cancer trials presents as oligometastatic disease at presentation when the mets occur. Survival again depends on the number of mets possibly. So less than 5 mets, 3.5 years. These are from the various studies. 6 to 12 meds, almost 2 years, and something less than 2 years if the number of meds further increases. So a number of meds is also an important. Now, the next big question is, all these oligometastatic disease, is systemic therapy the only option, or we need to add the local therapies also? So coming to the two important local therapies, yes, surgery and radiation. Should surgery be offered in metastatic breast cancer? And if yes, when should it be offered? So there are very, very special indications where one can think of these local therapies in a patient with metastatic breast cancer. So clear data does show that clearly selected metastatic patients. So the word to be highlighted is, it is a selected metastatic patients who may benefit from surgical management. Generally, the younger patient, those with highly hormone receptor positive tumors, or possibly the bone only disease. In inflammatory breast cancer also, now incorporation of local therapy seems to offer better overall survival. However, all the data that we have is generally retrospective, and we don't expect that we will, in near future, we will have a prospective randomized trial in this case. And a very common scenario, contralateral axillary metastasis. So again, a thought process, as was for supraclavicular lymph node some years back. Is it really stage 4? So in contralateral axillary metastasis, many of us currently offer local therapy also, in addition to the systemic therapies, and select patients may benefit from palliative local therapies also. So we have a lot of randomized control trials. However, majority are phase 2 trials, no phase 3 trials so far, which have shown that various histologies, whether it is prostate, lung, colorectal, or breast, and the addition of these local therapies in some form, whether it is radiation or surgery, may be adding on to the progression-free survival, and maybe some OS also. But the numbers are so few, and it is the data from very limited trials. Again, and upcoming something which is really very talked about with lot of emotions and positivity is SABR. It is SBRT therapy, radiation therapy, and we have much more data in this setting that does show that in the SPRT or local radiation therapy arms, these oligometastatic disease does better, and we have better local control, as well as possibly better PFS advantage also. So further questions will be answered by a lot of ongoing clinical trials. We have consolidative use of radiotherapy to block oligoprogression, and so many other things. And we have our learnings from certain other settings also. For example, in lung cancer, in oligoprogression, where we are frequently now adding local radiotherapy to systemic therapies. However, there seems to be a very, very long time before we can extrapolate this data to our clinical practice, because over a period of time the radiation technologies have really changed. There is the change in the surgical techniques, the systemic therapies have really evolved, better imaging modalities, the whole spectrum of oligometastatic disease seems to be changing. So there are lot many things which have happened. Can we extrapolate this data from our clinical experience to from the clinical trial to real world evidence? So we know that it is the real world evidence which is more important. Why? Because there is a continuous change in the radiotherapy technology, the imaging technology, the surgical things, and the generation of evidence from the clinical trials alone is going to be very, very unachievable and maybe too slow, and not all clinical questions can easily be answered by a clinical trial. So we have another ongoing very important clinical trial, that is the OligoCare, and the initial results includes lot many patients with lot many different sites. And for shortage of time, I'm not going into all these real world evidence. Also, some of the real world evidence from Belgium, England, and ongoing trials, which do talk about combination of these local therapies and not adding much to the toxicity, and improving not only the local control and to some extent PFS also. So metastasis directed therapy has now become a norm in has now been, rather I will say, not a norm. It has now become more acceptable in various conditions, in breast, in lung, and prostate also, so many other this thing. And yes, because why we are still lacking the definitive evidence, because of the large variability in definition that has been used in literature all across, and different definitions have encompassed everything. Some have talked about the outcome, some have talked about the disease burden, the disease type, and the disease sites also. But what is the consensus? The consensus is that it is independent of the primary tumor, it is independent of the metastatic location, and it is independent of the presence or length of the disease free interval. And it is a big spectrum. It can be synchronous, metachronous, systemic therapy induced oligometastatic disease, and not all of them behave the same way. The ability to deliver safe and clinically meaningful radiotherapy, rather clinically meaningful local therapy with curative intent to all metastatic sites, is a minimum requirement for defining the oligometastatic disease. In context of radiotherapy, it says for radiotherapy. So I would like to conclude by saying that at present there is a large variability depending on all these factors, but how we can summarize it is basically to say a limited disease, limited metastatic sites, less than 5 in most of the studies, and not more than 5 lesions in any one organ, a controlled primary tumor being optional but definitely more desirable, and at all the metastatic sites must be safely treatable. It doesn't depend, the term oligometastatic disease is not dependent on the primary tumor, neither it is on the site of the metastatic site, and the detection of oligometastatic disease may further increase depending on the further incorporation of high resolution imaging that we use in our clinical practice. And there is an increasing role of multidisciplinary treatment in management of this subset of diseases. With that, I say thank you.